And our speakers today, we have three speakers across Deloitte, Humana, and here at the Kelley School. Our first speaker today is Chris Stehno. He is Managing Director in Strategy and Analytics, Government and Public Services at Deloitte. Our second speaker today will be Gil Huff. He is Director of Clinical Analytics at Humana. And our third speaker today is Jonathan Helm, who's Associate Professor and GT Faculty Scholar here at the Kelley School of Business. So thanks for joining us, and I will step aside and let Chris get us started with his first talk.
Thank you, and I'm going to start by sharing a couple of slides here. So if you think I've got three people on the screen here, let's see why this isn't going into slideshow. There we go. I got three people on the screen here, person 1, 2, and 3. And if you look at them, from a medical perspective, they all look very similar. None of them have really had too much past medical history. They're all about the same age, say late 40s, early 50s. One of them had knee surgery, but that's about it. Another one is taking some allergy medication. If I were to use this information and try and build a predictive model that says which of these people are going to end up being my high cost claimant now or in the future, my model would be terrible. I mean, there's just really nothing to work on to really differentiate these people. And that's the problem we have a lot of times with healthcare. Is that people look alike until they get sick, and by then it's kind of too late. So what we want to do is try and figure out, well, how do we distinguish between these people up front? And this kind of brings up this whole area of what we call social determinants of health. So let's see here. What if I knew these other things about them? And sorry, this is a little bit small, but for example, what if person 1, I knew that they commute 45 miles to work each day? They maybe have poor financial indicators, maybe a bankruptcy. For health indicators, about all I know about them is maybe they eat a lot of fast food. The only exercise I can see is maybe they walk. But what are some other personal interests? I see that maybe they have high television consumption in their household. They order self-improvement books and so on. So I start to get a little bit different picture of person 1. Now let's compare that to person 3. This person commutes only 1 mile. They've got good financial indicators. They eat healthy food, have a very active lifestyle, are active in their community, are interested in foreign travel, and so on. So now if I were to take these additional data elements and build a predictive model, what would that tell me? Well, it would say the people like number 1 are more likely to have a higher BMI, a much higher BMI. They're going to have increased medical claims of 28% per year, and likely to have a depression claim over the next 3 to 5 years. People who look like number 3, on the other hand, actually have a much better BMI, overall have reduced medical claims, and are 2.5 times less likely to become a diabetic than normal. So this is how we've been using this social determinants of health data, drivers of health data, whatever you want to call it, to really start to understand more about an individual. And you may say, well, that's neat, Chris, but where do you get this data? Well, I already have it on every one of you on the call today. So we have one of the largest social determinants of health data sets that we're aware of. I've got every adult in the United States in it, so 230 million adults. Most all of our data gets updated every month. We collect about 1,500 raw variables on every person in the US. We built over 150 algorithms that correlate your purchase behaviors, hobbies, activities, etc., to your chance of having a disease or medical condition. And we use this in a whole variety of different places. We use it in, my background is actually healthcare actuarial. So we started with this data set over 15 years ago, using it for pricing and underwriting decisions. We use it for wellness. We use it in pharmaceuticals for understanding who patients are. And here more recently, we've been doing it a ton around COVID, and really understanding some of the health inequities that are appearing because of COVID. So I'm going to actually show you that. I'm going to show you a real demo of this data set. I'm going to have to stop sharing here so I can get back to the data set. Hopefully it hasn't timed out on me. So this right here is a data set. Let me just make sure I have it timed out. Nope, it's still working, looks like. Yeah, so this is a data set. I've got every adult in Indiana in it. So about 5.1 million people. They live at 2.4 million addresses. I actually can look at everyone in any state. We've got all states here, but we're just going to stick on Indiana. I've got multiple diseases and conditions that I've pre-modeled everyone in the state for and keep them scored at all times. So a variety of things we can look at. I've just clicked a couple here. And then we've got all these other social determinants of health stuff that we can factor on. And we're going to do some of this and just kind of show you how we can use this data. So for example, maybe I want to look at people that are of lower income or net worth. Maybe I want to look at people that are, we're going to look at people who are at risk of complications of COVID. That means they've had one of the comorbid conditions of hypertension, diabetes, cardiovascular, the stuff laid out sort of by the CDC. It's not telling you whether you're going to catch COVID, but it tells you if you catch COVID, you've got a much higher chance of having severe complications. Let's look at race. Let's look at the county you live in, and let's start to dig into this a little bit. Then also maybe I'm going to look at what some of the closest places are. Got COVID testing centers, hospitals, urgent cares. We want to play with some of those, and even pharmacy. And now we're going to start to cut into this data and see what we look like. So right now I've got all 5.2 million people. Let's start to look at the low income people in the state. So I'm going to choose some factors on income and net worth. You'll see this will start to drop our numbers up here. Now we're down to about 1.1 million people. Let's pick those people that are at risk of having one or more of the comorbid conditions that put you at risk for hospitalization, say, should you catch COVID. Now we're down to about 500,000 people. Let's maybe look at it by race. Maybe I'm interested in races of color, so Black, African American, and Hispanic, down to about 123,000 people. And then let's look actually at the Indianapolis area. So I used to live there. So I think that's Marion County, if I remember right. So now we're down to about 420,000 people. Now let's say, what if I'm only interested in those people that aren't close to a COVID testing center? I was going to put in here vaccination center, but I truthfully forgot to download that this morning, where all the vac centers were. So I'll just show you where all the COVID testing centers are, since I've already got that loaded in here. Now, when I zero in on this, every red dot here is one of these 2,000 households. And we'll see these neat little pods of people that have showed up. So what I'm looking at here now is everyone in Marion County who is low income, who is Black or Hispanic, who has high chances of having one of those comorbid conditions that puts you at risk of hospitalization should you catch COVID, and that is more than 2 miles away from, let's just say this is the vaccination center. This is actually the testing centers, but I can do the same thing for the vaccination centers. What I've just discovered are a bunch of pods of people that probably, especially if they're low income, they may have difficulty with transportation as well, that are not being served currently in Marion County as an easy way to get tested or to get a shot in the arm. So this is how we're using this data, helping states, the CDC, federal government, kind of to dig in, figure out where these groups of people are, where these pods are, where either, hey, I need to find a provider in this area. Like, for example, let's look at pharmacies. Are there any pharmacies in these areas that maybe we could turn them into COVID testing centers or vaccination shots? Here's one right here. If I hover over it, I can't quite, oops, hold on. Can't quite get my, this is a CVS, looks like on Brookville Road. Maybe we could start administering shots there. Here's a couple other that maybe we could use. We can also direct mobile vaccination centers to these areas. We can look to use schools. We can also show where schools or other areas of interest may be that we could set up these mobile vaccination centers. So this is a good example of where we have taken broad swaths of data, you know, the whole US population, adult population, built out models using social determinants of health to predict people who are at risk of diseases and medical conditions. And then through mapping technology, visualization, been able to lay this out across healthcare, you know, providers, or in this case, vaccination shots in arms, and pretty quickly realize where we've got issues, where we've got problems, and we've got large groups of people that probably aren't able to get shots in arms. So that is my demo. I don't know if we're taking questions now or at the end, but happy to do it either way. Any questions? If not, I will turn it over to the next person.
I actually have one quick question.
Sure.
I'd read a paper recently about, forgive me if I get this wrong, pharmacogenomics, which is using genetic characteristics to identify patients who are either sort of high risk for a particular drug or, normal or low risk, and then using that to make sort of tailored decisions. Is there any thoughts about using sort of, genetic information? It's relatively new, right? Probably in 2015 or something like that. But is there any thoughts about how that might be incorporated analytics wise into some of these decisions?
Yeah, I'm bringing up this list up for you again to kind of show it to you. And the reason I'm doing this, and we've got, hundreds of other diseases and conditions, but these are the ones that we're pretty good at.
Mm-hmm.
And the reason we're pretty good at predicting them is because most of the data that I have on you that I can get without your permission, these 1,500 fields of data that I don't need you to sign off on, isn't PHI. It's not health.
Right.
It's social determinants of health. It's like, do you play soccer? Do you spend money on soccer equipment? It's stuff like that. And so our best models actually work on what we call lifestyle-based diseases that are more influenced by the way you lead your life than your, genetics or anything else. Now, there are some diseases that are tied to genetics that I do have information on. If you think of like sickle cell anemia and some of the other diseases that are highly tied to race, ethnicity, other types of stuff. So we can do a little bit on those, but I'll just be quite truthful. Our models aren't nearly as strong on models based off of, or disease or conditions based off of hereditary factors as they are based off of sort of these social determinants of health factors. So hopefully that answers your question.
Yeah. No, I'm just interested in that. That is enlightening.
We have a question from Arjun Patel. Arjun, feel free to unmute yourself and ask the question.
Okay. Hey, good afternoon, everyone. So this is completely new to me. I never know about this analytics at such a minute scale. But how are the variables selected? And do you guys update it every yearly basis, every 10 years to bring in new variables?
Yeah. So the way our models are built is we actually do have health information I have it on about probably 1/3 of the US population. And the reason I have that is I do a lot of work for health plans, life insurance companies, companies that work in pharmaceuticals, other areas. And so to build models for them, they actually give me their medical claims experience. And so we use that as our target variable. I can't ever look up Chris Stehno and say, hey, Chris has this disease or condition, because that's PHI. But I can, let's say Chris has diabetes. I can take all the people with diabetes, use that as my target, and then append all this other variables, all these 1,500 variables to it to build out a model saying, what does a diabetic look like in terms of these other diseases, in terms of all this social determinant of health data. So we do have real underlying medical data that we use as our target variables. The data, earlier on when we first started doing this 15 years ago, the data changed quite rapidly. New data was coming in, databases were growing. So we rebuilt our models like every year or every 2 years. And primarily because new data was coming in, not because people's behaviors were changing or, what leads to diabetes changed over time. It was more, we were just getting new data. There continues to be more new data coming in, but it's slowing down, I would say, at least the sources that we can get at publicly. And so now we're probably rebuilding them. We recalibrate them every year and we rebuild them probably about every 2 years, just because of new data elements pop up that we think are valuable. I think I'm overdue on my time, so I'll let the next person go on.
Sorry, I had just one question about the use of the data. So when it came to the vaccine distribution, we are seeing a lot of pockets which have not got enough vaccine. So is your data set accessible, or does any of the state or federal government use this data set? Do you advise them on the distribution process?
Yeah, so we're using this data set in probably close to a dozen states now. And then also using it at the CDC, did some work at the National Institutes of Health. Initially, it was just when we first started this, say back in March or April, it was a lot around vaccination testing centers, where to put them that would most meet the needs. A lot of the data that I didn't show you is we have stuff on population density, density within a household. So we were looking at more of spread type of variables and how that is spreading through certain communities. Now we've switched full on to vaccinations and making sure that we're getting a fair distribution of those vaccinations. So yeah, the states that have contracted with us, it's available to them, just to the general public right now. I think Deloitte is trying to do something with the White House, is my understanding. I don't know if that's been actually finalized yet, but if it is, I can make sure, and that will then allow the data set to be open to the public. And if that does happen, I can sure send something around to this group and let them know.
Okay, awesome. And just one quick follow-up. So that determination, is it population density? I was reading something about a social vulnerability index that's being also considered.
Yeah, SVI is produced by the CDC. Social Vulnerability Index is the index they've had for years. It's a good index, but the way it does is it looks at census tract is, I think, the smallest level it goes to. It sort of looks at what's the average income, what's the average, education level, what's the average within, those areas. So it's good. What we're able to do with all those dots on a graph is a real household. I'm actually looking at similar data, and actually I even have more data points, and I'm looking down to a household. So ours is going to be a lot more relevant when you're getting to a lot smaller set. If I want to look at those neighborhoods, instead of sort of treating everyone in a census tract or a county the same way. So.
Awesome. Thank you.
Great, thank you. All right, let's move on to our next speaker. Gil, it's all yours.
All right, I've got a few slides to share with you today. I'll zoom through them. Let me get this off here. So yeah, there'll be some similarities, what you've heard from Chris's talks, but some different approaches as well. So we're looking a little bit about identifying social determinants of health and how it relates to COVID-19 responses and even the COVID-19 vaccination and so forth. So like we learned from the previous talk, Humana has been interested in social determinants of health, long before COVID. It's really kind of giving us that broader view of our member. We do certainly have a lot of data on our member. We have their medical claims, we have their pharmaceutical claims, lab claims, we have third-party kind of consumer data and so forth. So the approach that we took in trying to better understand social determinants of health, our chief medical officer was really interested in these validated screeners. So this is member reported, but we surveyed more than 100,000 of our Medicare Advantage members using a validated screener on SDOH from the Accountable Health Communities developed by CMS. We also did a good number of our Florida Medicaid members, and to try to understand which of our members and what is the prevalence of issues like financial strain, food insecurity, housing insecurity, loneliness, transportation, and so forth. So obviously we only have that for a subset of our members, and in a perfect world, we would love to be able to screen all of our members in January of every year and kind of have that perfect representation. We're certainly not there yet. I don't know if we will be. Could be in the future that providers, in addition to diagnosing diabetes and COPD and CHF, will be documenting some of these types of issues in the claims that they file and so forth, because there are ICD-10 codes for many of these social determinants of health. What we did is we took this screening data, say for our Medicare members, we have 100,000 screenings. We have a vast amount of data, like I said earlier, about our members, medical claims, pharmacy claims, lab claims, all this consumer data and geographic data and so forth. So we built the predictive model using the responses from those 100,000 members to kind of be able to identify which of our members are most at risk for a particular social determinant of health domain. So the one I'm showing you here is actually for transportation. So within the data, we saw about 11% prevalence for transportation challenges and so forth. So we have this predictive model. For those of you familiar, it's built in the standard way. About 8% of the data used to build the model, 10% to kind of refine it, another 10% held back to validate. Now we can score all 4.5 million of our Medicare members and have a pretty good idea which ones are at highest risk or most likely struggling with transportation challenges. So like I say, a prevalence of maybe 12% overall in Medicare Advantage, but we get in the top end of our model, people with the highest scores, and it's as prevalent as 55%. So this is really strategic in targeting members for different initiatives and pilots and outreaches. So we've built models like these for transportation challenges, financial strain, food insecurity, loneliness, housing insecurity, and so forth. So kind of have a suite there, and then you can blend those all together and get a kind of a social risk index and really start to piece together maybe where somebody is on struggling with some of these challenges. It was mentioned earlier about the CDC Social Vulnerability Index. It is at the census tract level. We've found it to be very useful and so forth. We did develop another index. I'd say we modeled this index off what Ash et al. Did up in Massachusetts. It's a little more granular in that it gets down to the census block group level as opposed to the census tract. They were looking to add these socioeconomic factors in a Medicaid payment model up there, but it's leveraging census data and really identifying challenging geographies. What are these census block groups that are most economically challenged, and this can give us a lot of index, even for a brand new member where we don't have as much clinical data, but if they're residing in some of these challenging geographies, there could be some great need there. We have an ecosystem. We do a lot of screenings in 2020, well over 1 million and so forth. So that data does all flow together and lives in a Power BI application to derive different insights on our members and so forth. And this is really kind of, let's say, kind of empowering the citizen data scientists. So not necessarily your high-powered modeler, this or that, but making this data accessible to many people to drive strategy and explore insights. In regards to how some of this was used in responding to COVID-19, analytics sits at the foundation of a lot of these activities, from trying to address access to care. Telehealth was vastly expanded, using social determinants of data assets to identify those who are most need. There are some initiatives where our list was actually sorted by that neighborhood stress score, putting those people likely in the most distressed geographies, first on the list to be outreach to check on their concerns and issues and so forth. So things were done, patient focused, try to manage financial strain and reducing out of pockets, enabling telehealth services, allowing, easier prescription refills, and even on the provider side, suppressing certain authorizations during this period, decreasing, kind of administrative burden and so forth. So there were a lot of activities, driven by analytics to help make things easier for both our members and our providers. One big activity we had was called the Basic Needs Program. There was a lot of concerns about the financial strain of our members, and so we used the SDOH insights to target members. Our CEO had wanted outreaches to all of our members, not that they would all be done in the same way, but high touch for members who had more complicated clinical or more severe SDOH issues and so forth. So outreaching the members, understanding their needs, different programs addressing loneliness and social isolation, but a primary issue was food insecurity. And during that COVID pandemic, over a several-month period, there were more than 1 million meals set out in the mail to well over 90,000 of our Humana Medicare Advantage members and so forth. So really the analytics to identify who's at greatest need and even kind of manage the fulfillment of all these things. I think this is my last slide here, but even recently here on the COVID vaccination, we've had a variety of partnerships. I mean, it's wretchedly difficult. The COVID vaccination guidelines and so forth is very decentralized. The federal government left it up to the states. CDC had guidelines, who's in phase 1A, who's in phase 1B and 1C, but that could vary from state to state. Even within a state, it could vary from county to county and how they're doing things and who's eligible for a vaccination at a given point in time. I know CDC used 75 and 65 as age cutoffs with their phased approach. I'm in Kentucky, they used 70 and 60. So just here recently, anybody in Kentucky 60 or and over, your phase is up, is available. So you can start scheduling vaccinations and so forth. So Humana wanted to be helpful, leveraging analytics, but it was vastly complex given that from state to state and county to county, things can be quite different. This is an example in Montgomery, Alabama, partnership with Walmart, and there was a fire and vaccine doses available, but really understanding where our members were using some geospatial analytics and so forth, and getting members lined up for vaccinations and putting out mobile vans and so forth to facilitate that. Because I mean, there's another group up in Chicago, the Oak Street Clinic, and a similar thing, and looking at members who currently qualify, who are geographically within a certain driving distance to these clinics, and being able to outreach them and try to facilitate and assist in getting those people lined up for vaccinations, because it's certainly has been and continues to be a huge endeavor. So that was kind of a bit of a whirlwind, but just to give you a flavor for activities that we have going on at Humana and how we're leveraging social determinants of health to get that broader view of our members and think about them differently. So happy to take a couple of questions if time permits.
I have a question.
Certainly.
Hi, Jill, or Gil. Thank you for this presentation. It's been really great. What was the biggest change you noticed before and after using this dashboard? And were there any cultural barriers to making decisions with it?
During the pandemic, we did some screening of SDOH with our Medicare members in the latter part of 2019. Literally, we know that would be great baseline data leading into the pandemic. More screening was done during the pandemic, and at least within our Medicare Advantage population, across all those domains: financial strain, food insecurity, loneliness, transportation. I mean, what do you think was the domain that was impacted the most for Medicare members?
Loneliness.
You're exactly right. Loneliness and social isolation is what spiked up. I think if we had more robust screening for maybe the commercial population and so forth, we probably would have identified some more increases in financial strain and things like that. I think we found that anecdotally in some of those outreaches as part of that basic needs programs and so forth. But no doubt 2020 has been a very interesting year. There's been a lot learned, and as we move into 2020, I think people wonder to what degree learnings will generalize and so forth.
Thanks.
Just a question on data sources. Apologies if I missed it. Where did the source data come from for the insights that were gathered?
Okay, so unlike Chris's presentation where he's running analytics around the full US population, we're
Right.
primarily running analytics across our members, so people that have health coverage with Humana. So in Medicare Advantage, that's about 4.5 million. Then we have some Medicaid members in select states and even some commercial groups. So it's a smaller group of people than the whole country. But at the same token, we have a vast amount of data because all of their medical claims come through pharmacy claims and lab claims. And we would have the broad set of consumer data there as well. And then the models were built off of survey data that we collected from our members as well.
Okay, wonderful. Thank you.
Certainly.
Any other questions for Gil? All right, let me turn it over to our final speaker. Jonathan, it's all yours.
Thank you, Jeff. And thank you to our other two speakers. Very interesting stuff you've got going on there. I'm actually going to shift gears a little bit, and I'm going to talk about, not about the patients themselves, but about the hospitals and the communities they serve. Okay, can everyone see my screen now? We good? Okay, cool. So this is a project that started out, and the way I'm going to frame this is a little bit different than our initial design. This started out with working with IU Health. Middle of March, when the first COVID patients showed up in Indiana, IU Health had asked us, in particular, a group of faculty fellows from the Center for the Business of Life Sciences here at Kelley, to help them design some analytics to respond to the upcoming COVID pandemic. So we built this for the largest hospital system in Indiana, and probably one of the largest, I think, top 20 in the country. And yet what I'm going to do today is frame this up in terms of a small community hospital, let's say in Anderson, Indiana, or in Greene County, because even though we built this for IU Health, which has these massive resources, the way we built it was intended to be easy to implement, low hospital commitment or resource commitment to get it done, fast, scalable, and flexible. So when we designed this, we were helping IU Health, but our goal was to have sort of a broader spread, a broader appeal. And to that end, we've been talking a little bit with the Indiana Hospital Association and whatnot. So as I go through this, I'm going to start by laying out what were some of the problems for hospitals in Indiana and really throughout the country at the beginning and as the pandemic progressed. And think of yourself from the position of you're a CEO of sort of a small hospital, let's say somewhere between 80 and 150 beds. That's kind of how we define small hospitals. You got a small team of management, mostly it's just doctors and nurses, okay? So we're going to start by looking at what does disparity mean from a hospital perspective rather than from a patient perspective. One of the things that sort of surprised me, but didn't totally surprise me, is that Indiana fared very well from a hospitalization standpoint during this pandemic. If you look on the bottom, that orange is Indiana, and you look at ICU bed utilization on the left and total bed utilization on the right. Compare that with Georgia. Georgia spends a lot of time up in the 90s, close to 100% utilization in both these categories, whereas Indiana never breaks 80% in terms of ICU utilization, or about 75% in terms of total bed utilization. So despite the chicken little, the gloom and doom, Indiana's doing pretty good, right? We never really had a situation where we were experiencing the kinds of things that were reported in the news and in a lot of other states. Okay. Well, here's how we did it. So the governor said, okay, at the beginning of the pandemic, and then again, when there was that second wave in September, the governor said, okay, let's cancel all elective procedures. And myself being a hospital operations person, I said, you know, this is a great idea because elective procedures are the #1 contributor to variability in hospital occupancy, and we can control them. We can, you know, move them out so we can clear space for COVID patients. Unintended consequences. Guess what happens when your revenue machine for the hospital breaks down, right? Basically, that's how hospitals make all their money. From what I've heard, many hospitals were losing as much as $1 million or plus a day. So $1 million a day. And this article from the Indy Star notes that many rural hospitals felt the sting even more acutely from their canceled elective procedures, right? These are very tight margin hospitals where, you know, they make enough from their elective procedures to continue functioning. But we already know that rural hospitals are at risk, and the COVID pandemic, again, targeted them more acutely than the big hospital systems like IU Health and St. Vincent's and Community Health and things like that, right? So here's the COVID bed utilization over the course of the pandemic. Again, we're looking pretty good, you know, and this is in terms of just COVID patients. So what fraction of our entire beds in the state are taken up by COVID patients? Well, never tops out on 20%, right? So Indiana's great. Now let's look at the counties in Indiana. And this is what I call disparity. Look at the two biggest counties, Marion and Lake on the bottom there. Their percent of COVID utilization, both in ICU and non-ICU beds, was 12% and 6%, 22 and 7, right? These are huge counties with lots of healthcare resources. Now let's look at Greene County, which is right next to Bloomington here, and Fayette County, right? So these are smaller counties, more rural. They have fewer beds, but not no beds. And you look at the number of COVID patients per beds, the utilization there, Fayette County's up at averaging, okay, so this is averaging over the 7-second wave, September through January, averaging 70% COVID only patients filling up their beds. That's not accounting for any non-COVID patients. In Greene County, well, you can imagine that not all those, not even close to, you know, half those patients are even staying in Greene County, right? 300% utilization of their 5 ICU beds. So really, who needs help? It's these small hospitals, right? How do we plan? How do we take some proactive steps to take some of that pressure off of our smaller hospital systems? They're more subject to flux in patient demand. They can't absorb the hits like Marion County, like Lake County. Okay, so analytics to the rescue. We're going to give a little background on what happened at the beginning of the pandemic. Well, everybody and their brother and their mother and their sister and their aunt started creating analytics to predict how COVID-19 was going to work. You see some famous names on there. We have Google, Harvard. We have, if you scroll around, we have Carnegie Mellon. We have MIT, Stanford, etc. Right? So we've got Johns Hopkins. We've got everybody making predictions for what's going to happen, right? How many cases are there going to be? How many hospitalizations? How many ICU beds? How many ventilators? Now take a look at this prediction. I just pulled this from October, just out of curiosity. This is the spread of the predictions. They went all the way from 4,200 cumulative cases, right? 4,200, not cumulative cases observed in November 1st, all the way to 22,000. The actual number was 9,300. Not many people got it on the nose. Ironically, Google Harvard seems to be particularly terrible. I was surprised at that. I thought they would do a good job given the analytics abilities there. So imagine you're a small hospital CEO. You see these, let's say 35 or 40 models out here to predict your census. What do you do about it? It's confusing, scary, right? I have no idea. There's all this information. I don't know what's good. And like, how do I choose? I don't even have a data science team to help me sift through these analytics. There's questionable accuracy. So let's take a look. Here's another poll I did. When the pandemic switches directions, these models stink. That's Google, Harvard, I think, right up here in the black, up near the top for Indiana. And you might make the argument that like none of these coastal predictors really care or know much about Indiana, but you know, they're analytics, so they should be able to adapt. So what do I do? I'm a healthcare company. What do I do? Well, here's the other problem. And here's the University of Pennsylvania's Chime app, which is probably the most famous outside of maybe University of Washington, funded by Bill Gates. But this one basically allows you to take your predictions of cases and turn it into hospitalizations. All right, so we've got all these parameters. And keep in mind, you have to input these parameters. Hospitalization percent. What percent of total infections get hospitalized? What percent need an ICU? What percent need ventilators? How long do they stay? Okay. So you're a hospital CEO of a small hospital in Indiana. What do? How do I put in those parameters? There's no guidance about how to put those parameters in. Also, if I use national averages, it's a terrible prediction for any given hospital. And that's what we showed when we implemented our model. National averages are awful for the state of Indiana. They are not good predictors. So how do I put these parameters in? How does this relate to my hospital? This is built for a state level prediction. How does it tell me about my community hospital in Anderson, Indiana, right? Yeah, it's very, very difficult. So that's basically where we stepped in. And we said, okay, we want something that's easy, that's quick, and that does a better job. So what are the problems? Well, it's the three bears problem, I say. A lot of the models are too simple. So like the Chime model basically tries to fit everything into an epidemiological model, right? So predict the disease, then multiply by percent that need an ICU times percent that get admitted times length of stay, right? Well, okay, but that doesn't really help me given that I have my hospital right now. I've got 7 COVID patients and I want to know what to do for the next 14 days. That doesn't help me. There's also these hospital flow models where they do these great detailed modeling, which we've done for years. I did my dissertation on it starting back in 2007. These models are really crappy because they don't take into account COVID dynamics. They just assume everything's the same as it always was. And so they don't do a good job either. Okay. Then there's the too complex. There are some very complex models that try to account for all possible factors. They're hard. The problem with these for small hospitals and large hospitals and anyone who's trying to implement quickly is they're difficult to estimate. They require lots and lots of data. They're time consuming to implement and they're difficult to update. So they have a lot of good features, but they are very challenging in terms of trying to get them quickly installed into smaller hospitals, rural hospitals that really are floundering out there without any kind of mechanisms to find this to support. Okay, so hopefully I've convinced you that there's problems with what was going on. Most of the models are built around public policy at the state or national level. Even when they go down to the county level, that doesn't tell me about, let's say, IU Health Paoli, right? Or IU Health Bedford. These are small hospitals in Southern Indiana, right? So I know something about the county. What does it tell me about my hospital? So what did we do? We said, okay, disease models are good for disease. Hospital models are good for hospital resources. Well, instead of trying to put them all together and do neither of them well, we're going to simplify things and we're going to break it into 2 pieces. We're going to have a disease piece and we're going to have a hospital patient flow piece, right? And each of these pieces is going to be simple enough that I can do a lot of really nice things in terms of rapid build, test, implementation. And we'll talk about a couple other things that this simplicity allows us to do that is not possible in some of the other methods. Okay. So why is simplicity good? Well, it allows us to do what we call adaptive learning. In these complex models, there's too many parameters. You can't really use the parameter tuning to effectively learn what's going on. Okay, so why do we care about adaptive learning? Well, it mitigates accuracy issues with respect to difficult to observe parameters. For example, what's the overall number of infected in Marion County? Well, we know how many tested positive. There's a lot of statistical results out there that say somewhere between 4 and 20 times the number of positive cases are actual cases. But how do we know? Is it 4 times, 6, 10, 20, right? So what we do is we enable our model to basically learn those parameters by observing the outcomes of what happens in the system, okay? At the beginning of the pandemic, there was almost no data. There was very little data on how the disease was spreading in Indiana, particularly not at the county level. There was little data about how long COVID patients stayed, what resources they used in hospitals. And the data that was there was what we call, it was censored, right? So most of the patients by the middle to late March, when we started implementing this, most of the COVID patients were still in the hospital. So how do we know how long they're going to stay? We've got a lot of unobservable parameters, like what's the real transmission rate? What's the fraction of patients that fraction of true infections that get tested, right, and show up in those confirmed cases? What are the impacts of quarantining, shutting down, reopening? Right? All these things are things that we could try to model, but rather we're going to learn it directly from the data by observing how the results evolve over time. Okay. How did it work? Okay, so here's our disease prediction model. Very simple. We have one tunable parameter. We basically created an SIR model, the simplest of disease models. And instead of trying to incorporate a bunch of complicated features to account for all the factors that could occur, we just have one parameter. We just tune what they call the R0, basically the transmission rate. And this actually blows pretty much all those other forecasting models out of the water that try to use more complex stuff. We're getting a mean absolute percent error on a 14-day holdout, 14 days. We're predicting 14 days into the future. Most of these models say, don't try to predict too far in the future because our models will suck, which they do. The other models, all the ones we've looked at, have more than 10% mean absolute percent error 14 days out. In addition, 10% is really generous. Most of them are up around 30, 50, and then there are some that are like 100, 200, right? You saw the 22,000 prediction versus the 9,300 actual. So there's a lot of variety, a lot of variability. We're able to produce consistently accurate forecasts with a very simple model. And that's because we're not epidemiologists, we're operations management people. So we didn't even think about how you should build an epidemiology model. We just thought about how would we optimize this and adapt it to dynamics that we can't possibly predict. So we came up with a different approach. Forecasting census. So once we take that disease model, we predict what fraction of them are going to come into the specific hospital that we're modeling. And then we predict how they're going to move around that hospital based completely customized to that hospital's specific data. How do we do translating disease cases into actual admissions to a specific hospital into projections for hospital census? Well, if you look at this, this is basically actually applied to IU Health. I didn't put the numbers there, so you can't see exactly when it occurred or what it was, but mean absolute percent error of 9% in the ICU. ICU is a little bit more tricky because there's more complicated patients there, and 8% in the medical surgical. We've since done better than that, but we hardly need to, because any of the other models that we've looked at, that we've found in the literature that the state is using, the state of Indiana is using, have mean absolute percent errors between 25 and 50%, and even greater than 50%. So again, the simplicity combined with some adaptive learning is really nailing it. And the beauty is it's super easy to implement. Okay. Here's just a picture of the dashboard. This is, again, with sort of made up numbers, so I don't want to give away IU Health's proprietary data, but it's similar to that Chime dashboard, except it's completely customized to any particular hospital based on their data. You can cancel some ICU arrival, cancel some elective surgeries and see what happens to your census. Back to remember how they canceled elective surgeries for a surge that never came. So these small hospitals got slammed by financial losses and they didn't need to. Well, that's exactly what our dashboard allows you to do, is to say, look, here's our prediction of how many COVID patients are coming. And if you cancel this % of elective surgeries, you'll be able to handle them instead of canceling all or canceling none, right? So in retrospect, if we had been able to use this, if someone had asked us to use this, or, well, the governor mandated, but if the governor hadn't mandated and people decided they wanted to cancel some elective surgeries, you don't have to cancel all. You can mitigate that financial disaster while still serving the COVID patients properly. Okay, I'm going to wrap with this. What are some of the benefits of our sort of parsimonious, simplistic approach with respect to the little guys, the small rural hospitals, right? Even without me, IU Health would have figured something out. They have so many resources. They have a huge data science team, right? They've got a large IT team. They can figure it out. Not these smaller hospitals, okay? So what benefits does this bring? Rapid build, validation, implementation. The simplicity makes it very easy to make sure that we're making accurate predictions and not making mistakes. It's easy to build up these models. They're very simple, very small, just a set of systems of equations that we can do. Easy to implement because of their simplicity, right? Minimal hospital resources required. This is one of the #1 reasons why analytics don't go in hospitals, because they feel like it's going to be too much effort to put it in and use it. Okay? So in our case, it doesn't require hardly any resources for implementation or ongoing maintenance, because we've automated a whole bunch of stuff and the data requirements are extremely simple and do not require a lot of effort on their IT side. They're standardized data requests that are simple to pull, that everyone has regardless of the EMR system that they have. Okay, we call this plug and play. Like I said, data needs are simple. Does not require a decision science group, which many hospitals and hospital systems do not have. Right? Minimal integration with IT systems. All we need is a data dump. We don't even need to integrate with IT systems. Just pull a data dump, throw it into a set of equations that we put on their internal server, and pop, you get your answer. Okay. Minimal software design. There doesn't need to be a whole lot designed here. Again, the simplicity, the parsimonious approach is serving us in terms of easy install. Okay. And the coolest thing is that by taking this simple approach, we are able to do this adaptive learning that you can't do with these other models because of all the parameters that they have and the complexity, which does capture a lot of features that we're not capturing. But what happens is our tuning is able to overcome the fact that we have a simpler model and we're not capturing all those features, and in fact, surpass those models that do capture more features. How does this relate to smaller hospitals? Well, guess what? Those big models that count for a lot of features, they don't account for rural counties. They're looking at big counties. They're looking at New York City, LA, San Francisco, Chicago, Indianapolis, right? Detroit. These were not designed to work with rural counties, rural areas. There's less data in rural counties. They look way different than urban areas. Okay, so these models just don't work at all. Ours do because of that adaptive learning. The other thing is it automatically adapts to changing dynamics. The government, the governor puts us on shelter in place. Remove shelter in place, but has small gatherings not allowed. Then we allow small gatherings. We open bars, we open schools, we open restaurants, right? All these things are very, very challenging to predict how they're going to impact society and even human behavior, right? So if you notice, if you go back and look at the data, our cases started to spike before they lifted shelter in place. Why is that? Because people got tired of sheltering in place and they just stopped doing it. right? So how do we predict all that stuff? No, we just adapt to it. We learn from it. Okay? Little intervention required to keep the model current. A lot of these models, you got to like continually, if you want them to be accurate for a particular hospital, you got to continually update them. Ours have very simple updating routines that just automatically take new data and automate the process.